Hi, everybody. This is Professor Dunham, and I'm going to continue to discuss Chapter 6 with you. Okay, so where I left off yesterday, I'm going to continue today and talk about what should we do with the woman in labor. So how are you going to monitor her? Okay, well, don't forget, always take her vital signs, and you always will monitor her blood pressure, pulse oximetry, her temperature. And then you're going to look at the contractions. You should be on the electronic continuous monitoring, and you'll monitor the contractions. You don't want the contractions to be too close together. That would be what we call hyperstimulus or tachysystole. Those are contractions too close. We want a really nice pattern of 2 to 3 minutes apart, lasting 60 to 90 seconds in duration. And then we're going to watch her progress to labor. She should be dilating according to that Friedman's curve. And so we want to go ahead and monitor, make sure she's progressing. And then intake and output always. In labor and delivery, we do give a lot of fluids. So we want to make sure what we put in is what we get out. And of course, the last is very important is her response to labor. Okay. Our role in the labor room as a nurse, we are helping her cope with the discomforts of labor, helping her breathe with the contractions, and giving medication if she wants to at the right time. Such as if she's in the active phase and she wants a little narcotic to take the edge off the labor pains, that's okay. Remember, the only thing that takes away the real pain of the contractions would be an epidural. And during the active phase of the first stage of labor, an epidural, if she wants it now, would be a good time to give it to her. Okay, let's move on. So we talk about the 6 Lamaze Institute basic practices for maternity care. And what this is all about is, labor should begin on its own. Okay, so we're not going to induce someone. Well, we don't really induce them until they go really post dates or there's a medical problem with mom. That's when we'll induce. But we don't induce just to induce because Aunt Mary's birthday is falling on such a date and she wants to be delivered. We don't do that. Women should have freedom of movement. Yes, in the hospital, they do have freedom of movement. I get my patients up on the birthing ball and they can walk around. As long as they're not on Pitocin, they have freedom of movement. And of course, excuse me. And of course, if the baby heart rate is within the norm, 110 to 160, they have a lot of freedom of movement. And then have a support person. We do believe in that, or a doula if they don't have somebody to help them in the labor room. And no routine intervention should be performed. Well, we don't do that. We actually limit how many sterile badge exams we do to a woman. Okay. And then women should be in a non-supine position. Well, I'm going to tell you, I never put my ladies in a supine position because they can get that supine hypotension syndrome. And I don't want to create that. And I don't want a baby to have a problem, his heart rate go down. So I always have my patients in a lateral position, sitting up position that she's comfortable and can breathe very well. And then women should not be separated from infant. No, we don't do that. When baby comes out, we do the kangaroo skin to skin contact right after delivery so that their bonding goes on. So if I was to ask you a question, a woman in active labor experiences spontaneous rupture of membranes. Which nursing actions are appropriate at this time? Well, if you look at the choices, and this is a select all that apply. So what the question is asking me is the woman's in active labor, okay, and she now has spontaneous ruptures. So when she has very spontaneous rupture of membranes, I know to record the color of the fluid. I know to monitor the fetal heart rate for a full minute. I'm going to record the time of the spontaneous rupture of membranes because we only have 24 hours from that time now to get her delivered. And we're going to record the amount of fluid. Yes, is it scant amount? Is it a moderate amount, a large amount? And that tells me a lot too. And then, of course, I mean, going back to the color, I want to know what the color of fluid is. Okay, so those are the ones that I would select to answer this question. So our job is to help the woman cope with labor, okay? Give her lots of labor support. And if she doesn't have someone there, she has a doula, okay? Now, doulas are certified and they go through a big certification course. I know that for sure. And they are trained to provide emotional and physical support during labor and delivery. I would definitely know that. Probably see that one again. We do a lot of teaching. We do a lot of reinforcing teaching. We breathe with our patients. We let them know what's happening. We inform them. If we do a sterile vag exam, we say, I'm going to now do a sterile vag exam to find out your dilation. Is that okay? And she said, yes. Once I get in there, I'm telling the patient, I feel the baby's head, you're 3 centimeters, and you're completely effaced. So you're really making progress. Okay. Again, that's also teaching, informing, good communication, and providing encouragement. Okay. We're very encouraging people because we want her to keep going, because we need her to keep going. Okay. Because a lot of women just say, I can't do this anymore, and they give up. And our role in that room is to give them emotional support. Now, I'm going to go into the stages and phases of the labor, okay? And so I'm going to go through this, and then I have different slides to show you that goes over each one. So the first stage is where mostly dilation and effacement. That's the most active role. It's your longest stage of all of them, and it can last up to 20 hours, you know, it's not easy to dilate, especially if it's the first baby. It's not easy to dilate and face that cervix. Okay. And what we did is we have 3 phases of that first stage. Okay. So you have the latent or early phase, you have the active phase, and then you have the transition phase. The second stage is now you're completely dilated. She's pushing. This is a pushing stage, and she's going to deliver that baby. She can push anywhere from 30 minutes up to 2 hours. The third stage is the placenta. That takes from 5 minutes to 30 minutes. And the fourth stage is your recovery, which in the LDR is usually 1 to 2 hours based on mom's response and what kind of anesthesia she had. And then she'll go to the mother baby unit to start her complete postpartum period. The postpartum period actually lasts up to 6 weeks. And then at the end of the 6 weeks, she'll come back in and her obstetrician, gynecologist, have her 6 weeks checkup, talk about future contraception, and then go on from there. Okay, so here I made a slide for you. So you can see here, the first stage is the longest stage of labor. The latent phase, or you could call the early phase, is the beginning of true labor until your patient reaches 3 to 4 centimeters. Okay, your patient's really pleasant and she's talking. Good time to get those permits, consent forms signed. The contractions are usually mild, and the frequency is, maybe 7 to 10 minutes, with duration of the contraction like 15 to 20 seconds. Is starting. Again, just like I said here, it's the beginning of true labor. Then as she dilates to 4 to 7, she goes into the active phase, okay? The contractions will intensify, and now your patient is experiencing more discomfort, okay? I put in here, this is the good time for that epidural if you want to give the epidural, because it's the most effective time, because 4 to 7, she's really dilating quite big. and the head, the baby's coming down, and it hurts. Okay. So we might as well, if she wants an epidural, might as well give it to her during this time so she gets the biggest advantage to it of not having any pain with the contraction. Now, the transition time is now your patient has progressed to 8 to 10 centimeters. The contractions are very, very painful, and the head's coming down. So she might feel like a really strong urge to push. So, at this time, you don't want to give a narcotic, okay? And you don't want her to push until she's 10 centimeters. Okay. Okay, let's go on. So the second stage of labor is your patient is completely dilated and it's time to push the baby out. Now this stage, like I said, lasts from 30 minutes to 2 hours. And if the baby is in the occipital posterior OP position, then pushing could be longer, okay? Because remember, in OP position, the baby's chin is up in the air, it's not coming down. He's not tucked down really nice. He's going with this chin up. So it would be harder, pushing would be harder and longer. Now, if mom gets tired after 2 hours of pushing, then she may have to have an assisted device such as forceps or a vacuum extractor. Remember, the forceps would make a little mark on his head, okay, because these are stainless steel blades going over his head. And then mom will push with the contraction, and then the obstetrician will give that counter pull and help get that baby through. Sometimes when the baby's head goes around the symphysis pubis, that's where it gets a little tight. Now the vacuum extractor is another assisted device. It is like a little circle cap and we put it on the baby's head, all right? And then we have pressure. Now, what you can see when the baby's born is that he may have a little circular mark on his little forehead. That all goes away. Now, your third stage is the getting delivery of the placenta. Okay, and you have the Schultz, which is the neonatal side. It's called, like I was nicknamed it, the shiny Schultz, because it's shiny. It looks really pretty. It's shiny, and that's the neonatal side. The other side, the flip side of that, is called a dirty Duncan. That's how I learned it, and it does work. Kind of gets my memory that that's the Duncan. It doesn't look so pretty, not like the neonatal side. Okay, but you want to make sure that all the pieces to the placenta is there, because if you leave a piece up in the uterus, that's not good. That could be retained placenta fragments, cause your patient to really bleed, go into postpartum hemorrhage, all right, which can lead into hypovolemic shock, which is never good. Okay. Now we go into the fourth stage of the labor process. And this is, again, the recovery, all right? So this is your nursing care. It includes, you want to make sure that you identify and prevent a hemorrhage. Just like I said, the retained placenta, you want to make sure that placenta is all intact. And as an LPN, you could be in the room with me, and basically you'll look at the placenta and you want to make sure all the lobes are there, okay? I'm going to check her fundus. Remember, you go up on the belly, and her fundus should be the uterus, and the fundus is the top of the uterus. The uterus should be at the level of her belly button, her umbilicus, okay? That's where the uterus is after delivery. All right. And you want to make sure it's firm. If it's not firm, you're going to take your hand and massage her fundus. All right. Now, I'm going to evaluate, and if I need to, intervene for her pain. I'm going to do, what's your pain, Mrs. Jones, on a scale of 0 to 10? 0 being the least, 10 being the greatest. Okay. Observing the bladder function and urine output. Absolutely. If her bladder is full, is going to displace that uterus. So what happens when the bladder is full, remember the bladder lays right underneath the uterus. When the bladder is full, it pushes the uterus up and it will deviate it over to the side, all right? And that's not good because she'll have more bleeding because of that. So what are you going to do? Empty the bladder. Okay, so empty the bladder, get rid of all that urine, record her output, and now check her uterus, okay? It comes back to midline and at her umbilicus. That's perfect. Okay, and then I'm going to evaluate her recovery from anesthesia. Did she have a pudendal block during the second stage of labor for maybe that episiotomy? Or does she have an epidural, which I have to check her dermatomes in order to know what is still anesthetized, kind of sleeping yet, because I don't want to get her up if she can't not support her weight. All right, because she could fall and hurt. All right. Now, providing initial care to the newborn, yes. You can be doing her APGAR, the baby's APGAR scoring, instilling, and putting in the erythromycin eye ointment. Those are things, and looking at the baby, you know, so APGAR, the eye ointment, vitamin K, and observing for any abnormalities. Okay. And then, of course, we're going to promote bonding and attachment between the infant and family. Bonding is our beginning. Bonding is a real emotional time. You have the mommy and husband in the room or her partner, and bonding is quick, okay? You wanted that to happen. Attachment is over, that happens over time. So another area I want to touch on is our VBACs. That's our vaginal birth after cesarean patients. These are our special patients. These are patients that maybe had a C-section, okay, for our first baby who was breech. Okay, so they did a transverse cut on the uterus, which is called a Flanagan-Steele cut. Okay, so that means that she could labor. You can never, now listen up, you can never give this type of patient Pitocin. You can never induce the patient, and you can never augment the patient with Pitocin, okay, because you could cause that uterine scar to rupture. So and all the time that when I had a patient that was a VBACing, you have to be always on alert for this uterine scar that she doesn't have too many contractions at one time that she would rupture. Okay, because you know the uterine rupture would affect the placenta blood flow to the baby. All right, remember when mom doesn't get enough blood, all right, and she goes, therefore she's not getting a lot of oxygen, that will also carry to the baby through the placenta. The placenta blood flow is definitely disrupted. Okay, it's definitely diminished. And then, you know, she could hemorrhage. So you have to be very careful with that. And then she may need more support than other laboring women because she may be scared, apprehensive, because, you know, at any time, anything could happen and we'd be going back for a STAT, emergency C-section. And then nurses, we always give empathy and support, okay? And we work with the patient. If she wants to try to do a VBAC, okay, on her second baby, that's fine. We'll work with her. As long as that uterine scar on the uterus is transverse. It's called a Flanagan-Steele scar. Okay. Now, what are our nursing responsibilities during the birth? Well, this is where I have a lot of LPNs that work in the labor room. This is how they help us because the RNs are caring for the patient during the labor. And then, you know, things go very quickly in labor and delivery. So they help us with the delivery instruments and get them set up because the nurses, we have to set up our own tables. Get the infant equipment. That means that radiant warmer, get it plugged in, get it in the room, get it plugged in, get warm blankets in that radiant warmer, and make sure we have everything we need, including oxygen and suction, and everything is working. So you would be checking that equipment, which is very important because, again, once that baby comes out and he's having maybe a hard time breathing because he has a lot of fluid, we had to make sure that the suction is working. Maybe do a little peritoneal scrub. Remember, it gets kind of messy during the labor process. So, we have blood, we have amniotic fluid, we may have some excretion down there. So we want to make sure we get it all nice and cleaned up. Giving medications, providing initial care to the infant, like I talked about, assessing the APGAR score, assessing the infant for obvious abnormalities. Okay, I'm thinking, if you have a spina bifida baby where the meningeal are on the outside of the baby, that's very important to pick up very, very quickly. Examining the placenta. Okay, we talked about that. And this is here, putting the identification bands on mom and dad, and then the baby. Okay, it comes in a set of 4. So 2 go on the infant, and then 1 on mom and 1 on dad, or whoever she selects as the primary person. And then promoting parent-infant bonding. Okay, again, we want to make sure this baby gets bonding. So a little brain teaser for you. The nurse is caring for a woman who is delivering her first baby. So which of the following indicates the woman is in the 3rd stage? So the question's asking me, which of the following indicates I'm in the 3rd stage of labor? And now you think, okay, well, we know what the first is, we know the second. Oh, it's the 3rd. The 3rd stage is the expulsion of the placenta. There you go. Now, nursing care immediately after birth. Okay, now, I'm mom. We talked about this already, so I'm just going to go this real quick with you. Observing for hemorrhage. Check that uterus. Make sure that that fundus of the uterus is firm, okay? And then look at her lochia. The lochia at this time would be rubra, because lochia rubra lasts from 1 to 3 days after birth. So it would be red. Do the vital signs. What's her blood pressure? What's her pulse? Okay. So I want to make sure that, everything's within norm, because it's very normal after birth that the mom's heart rate goes down. And so we want to make sure that it's still okay, and we want to see if it goes down. Make sure she doesn't go tachycardic on you, because that would be a sign of a hemorrhage. Okay, check her skin color. Is she real pale? Is she doing okay? And then, of course, for pain. The pain scale, again, making sure that you give her comfort measures. And, a nice thing, too, after you deliver, you've been real sweaty during the labor and pushing stage, have a nice, clean gown. I always believe in this. It makes the patient feel much better. Get a nice, warm, clean gown on you, get her cleaned up, get her dry. There's a lot of fluids with labor and delivery, and so we get them all dry. Okay, and then put an ice pack to her perineum, because the ice, the first 24 hours, helps to reduce swelling and bruising. So remember, ice first 24 hours to reduce swelling and bruising. You'll probably see that one again. Okay, so if I was to ask you, the nurse is observing a patient for hemorrhage and following a delivery. So which assessment finding indicates a maternal hemorrhage is occurring? Okay, so the question is, which assessment am I finding that tells me my patient is hemorrhaging? All right, well, I know tachycardia is my first sign of a hypovolemic shock. So if she's having tachycardia, she probably has lost a lot of blood. She has a continuous flow of bright red bleeding, okay? That's not good, okay? So we want to check that fundus to make sure that it's firm. Boggy uterus would cause a continuous flow of bright red bleeding. She's saturating a peri-pad real quick. And those pads in labor room are pretty big and they're pretty thick. And if she's soaking 3 pads within 1 hour, we've got too much bleeding going on. Remember, a hemorrhage is going to lead into too much bleeding is going to lead into hypovolemic shock. Don't want to go there. And then she's passing large blood clots. These are all telling me that my patient is in trouble. How about another brain teaser? The nurse is assessing a client post-delivery, and she knows that the uterus to be high and displaced to the side. Oh, I think I just said that. Okay, so which is the nurse's priority action? Okay, so it's high, the uterus is above that umbilicus, and it's over to the side. I know my anatomy and know that the bladder lays right underneath that uterus. So what do I have to do? I have to assess for bladder dissection. Okay. Another one, which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Ah, okay. Well, I know if she has bleeding, she has bruising in the perineum, I know it gets edematous, then I want to put ice packs on that perineum to decrease that. Okay. Now, just giving oral narcotic analgesia it's going to wear off. It's not going to take the swelling down, and it's not going to take my bruising down. So, a warm compress, you want to put ice in the first 24 hours because ice is your best anti-inflammatory. Then after 24 hours, you could now go to the sitz bath, which will be have warm water, and that would be nice. Okay, so let's go ahead and look at the baby. All right, so the baby, there's 3 phases that the baby goes through. Okay, let's see. I mean, he's just been thrown out of his home, I just say. He got evicted from his home, so he has to adjust. So he goes through phases. So phase 1 is from birth to 1 hour. That, again, is usually right in the delivery room and the LDR. And so the time, for bonding with mom and keep him warm, because thermoregulation is the biggest problem with these babies. Keep them warm, have them bonding. You can breastfeed even. And then before they leave the LDR, you want to put the eye ointment in and the vitamin K. Okay. And this time you're banding the baby and you're doing footprints. A lot of times I did footprints on Daddy's t-shirt. They had a t-shirt that they wanted to have footprints on. We do things like that. Now, phase 2 is from 1 to 3 hours. So this is a good time that mom's going to be getting cleaned up in the LDR. Okay. And baby's going to probably go to the nursery with dad because he has that band on him. And they're probably going to look at the baby in the nursery, because that's called a transition nursery. And the baby's not going to stay there very long, because once mom gets to the mother baby unit, the baby actually goes with mom. And so that's phase 2. Now, after 2 hours, after they get done with phase 2, they go to phase 3, and that can be from 2 to 12 hours. And usually that's in the postpartum or the mother baby unit, because in all the hospitals today have rooming in. Okay, it's just safer too to have the baby in the nursery in the room with mom. Now, on phase 1, we're going to take care of this baby. Remember, it's the first hour in the delivery room in the LDR. I want to make sure my baby stays warm. So remember the radiant warmer radiant warmer I talked about? Okay. I want that on before this baby's born, so the baby comes out and he's not going to get cold, because you don't want to cold stress a baby. All right. Do not cause cold stressing baby, because babies, when they're cold, will go into respiratory problems. They get real tachypnea, and they can have respiratory problems, and then you got some more problems. So you got a cold baby with respiratory distress syndrome. That's not a good thing. So I want to make sure this baby stays nice and warm. I got warm blankets. So after he comes out, he's wet, and he hits this cold room. So we have a blanket. and we're gonna, just dry them off and put the warm blanket around them and put a little hat on them to make them feel really cozy and warm. I'm going to check the cardiorespiratory function. I check that by doing the APGAR scoring at 1 minute and 5 minutes after birth. Okay. And you want to make sure that babies come out with a lot of fluid. So you want to make sure you have suctioning and you have the bulb syringe too. You want to observe when the baby urinates. All right. A lot of young male babies, when they come out, they will urinate very quickly. Okay. And so you have to make sure that they do urinate in that first 24 hours. And you want to make sure that you see that passage of meconium. Okay. Meconium, remember, is the first bowel movement the baby will have. Identify, here's your identification again: mother, father, and the newborn. Okay, that newborn does not go out of the OR if it was a C-section. No, it does not go out of the OR, or it does not go out of the LDR, okay, if it's a vaginal birth, because every baby needs to be identified. You do not want to run into that kind of problem and have mix-ups. It can happen, but you don't want it to happen. And then performing a brief assessment for major anomalies, like we talked about, encouraging bonding and breastfeeding. So this is what happens during that phase 1, the care of the newborn. And here I have a picture. You can see the radium warmer, all right? And I see I have suction available right there. And see, actually the tubing is from the suction canister right into the crib. Got oxygen. And there's a bulb syringe, plenty of blankets. Baby's keeping warm. Baby looks good. The nurse is, looking at the baby, again, observing for any kind of abnormalities, checking the cardiorespiratory system, and doing APGAR scoring. Okay, a lot goes on. And don't forget the identification bands. All right, so here you have in the OR, because Daddy is here, and Daddy has a mask on and cap on, and he's actually bonding with his baby, which is lovely because Mom probably is getting sewn up over there. And there's a bowl syringe, again, radium warmer, and this baby has a temperature probe on, and this probe is actually plugged in to the radium warmer, which is you put it at a setting that is will keep the baby warm, and it actually monitors the temperature so that of the baby, so that you don't overheat this baby. Okay, and which is nice because it's you set the radium warmer on, and you don't want to overcook them because that would make him have problems too. So you want to maintain a nice stable temperature, and this will let you know. So the baby is good. Okay. So your APGAR scoring is a special score devised by Dr. Virginia APGAR. Okay, Dr. Virginia APGAR. And what she did, she came up with a system, and it's where you're looking at these areas after birth: heart rate, respiratory effort, muscle tone, reflex response to when you suction or you do general stimulation to the baby. He'll respond, and you want to look at that response, okay, to what you're doing. And then the skin color, you want to look and make sure that the baby's got skin color. The babies that are pale or blue, they're not getting what they need to get. They're not getting oxygenation. They're not getting blood. So that's a problem. But usually babies come out and they're the trunk of the baby is usually pink at 1 minute. And then their little hands and feet could be blue. That's called acrocyanosis. And that's normal. Okay. Now it does get maybe daddy's upset, or daddy's going to into the recovery room and say, my baby's hands are blue and their feet are blue. That's okay. It takes time after the baby's born. And remember those shunts, those 3 shunts that we talked about before? Well, they all have to close. So then the circulatory system has to change completely. So that takes time. So maybe it takes longer to get blood flow to the hands and feet. So it should acrocyanosis should resolve itself, say, within after 24 hours. Okay. Now, an APGAR score of 7 to 10 is great. The baby's good, and so it's really good, because don't forget, you're looking at all the color, the heart rate, the reflex irritability, the muscle tone, and respirations. Now, if he's a little sluggish and he's getting like a 4 to 6 and on his scoring, then he needs some moderate resuscitation efforts. Okay, maybe give him a good rub down, get him crying, get him agitated. Crying usually helps a lot, because crying makes them pink up. Okay, makes that blood circulating. So crying is good. And again, we want him to cry, because that's part of the respiratory effort, is crying. And so if he doesn't cry, then you're giving him a 0. If he has a weak cry, he's trying, you give him a 1. And he has a nice vigorous cry, you give him a 2. Isn't that great? Okay. So I usually try to get them stimulated and little, flick the little feet, and they usually get a little irritated when I do that, which is good. So we talked about heart rate. It has to be present. If it's absent, it's a 0. If it's under 100, you give them a 1. And if it's more than 100, you give them a 2. All right. So the heart rate. All right. Okay. All right. And then respiratory, we talked about muscle tone. If they come out and the baby is called what we call flaccid, he's just laying there. It's like, okay, I'm here. And he does nothing. He gets a 0. And then some flexion, he gets a 1. And he has total flexion, he gets a 2. Okay. And then downward reflex irritability, again, no response. So like you do a little tapping of the foot, and he does nothing. He gets a 0. You have a slight response to the foot tapping, he gets a 1. And if you have like good quick foot removal, he pulls back his little foot, he gets a 2. And then of course we talked about color. If he's dusky, cyanotic, got some he's blue, he's pale, he gets a 0. Acrocyanosis, he gets a 1. And then totally pink. He's totally pink. That means his trunk, his little hands and feet are pink. He gets his 2. All right. Now, just don't wait until a full minute. A 1 minute APGAR is assigned to begin resuscitation if the baby is a compromised baby. I mean, obviously, as soon as baby comes out, we want this baby to be reactive. All right. And the APGAR score is 6 or less at 5 minutes. Requires an additional APGAR assessment in 10 minutes. That baby will get a 10-minute APGAR in the nursery. He'll be in the nursery getting assessed. So this is another way of looking at it. And so they use the word APGAR to kind of stir your memory here. And so A means appearance or the color. The P is for the pulse or the baby's heart rate. The G is for grimace, his reflex irritability. A is for activity, muscle tone, and R is for respirations. Okay, and then we talked about the medication in the LDR for the baby. All right, so you want to put some eye ointment, and you're doing this prophylactically, actually, in the delivery room, and that is the erythromycin eye ointment. And you're going to put it so that it's on the lower conjunctiva, and you do it in what we call a ribbon fashion. ribbon fashion. I'm going to tell you, the HESI likes to know that. Okay, they usually have a question about that. And then also in the LDR, when you're looking at baby, don't forget you're looking at his back. And if you see any like spina bifida where the meningocele is outside of his back, it's like in a sac form. You want to take note to that. Or hydrocephalus. And look at his lip and see if he has a cleft lip. And we usually take our finger, and we don't forget we have gloves on, and we check the palate and make sure that has all come together, because that's also problems for the infant. Don't forget that open neural tube, it closes during the embryonic stage, okay? And sometimes there's a failure of that to close. So then you would see these abnormalities such as the spina bifida and the hydrocephalus. Okay. We also talk about giving the vitamin K, is because the babies are born with immature livers, and so they don't have the ability to make blood clotting. All right. So you want to give them some vitamin K, and you always ask mom, and you always get a consent form for it too. But it's a good thing because it helps with decreased bleeding, especially if they're going to have a circumcision. So those are things we talked about. All righty. And another two, you're looking for major anomalies or abnormalities in the labor room right after birth. How about any head trauma from the delivery? When we have a baby who's coming down the birth canal, things can happen. And so they come down too quick. Sometimes they can get a cephalhematoma, or another problem could be a caput succedaneum. The succedaneum is the caput is usually the back of the head, occipital area, and it's a collection of fluid. All right. The cephalhematoma is usually on the side of the head, and that's a collection of blood underneath the scalp. Again, those are things from maybe mom's pushing, maybe prolonged pushing. Things can happen. Trauma can happen. We try not to happen during the labor and birth. All right. And then two, if they had an assisted device, such as forceps or that vacuum extractor, all right, these are things that can also cause problems to the infant. The forceps are stainless steel. All right, and I told you before, you can leave a nice forceps mark on the baby's head, or the vacuum extractor can cause a circular, swelling on the side of the head. All these things do go away, all right, as long as it's not too traumatic. And now we also look at symmetry and are the extremities equal? Remember, that was part of the amniotic fluid. That's why it's good to have that amniotic fluid, because it allows the arms and the limbs to grow symmetrically, even. And so we want to look at that too. All right. Okay. And when you're looking at for equal length, do they move with the same kind of vigor on both sides? Do they move the same way? Is one sluggish, one faster? You want to take note to that. And then you want to look at the hands and feet. Are there extra digits? Okay, because sometimes an extra digit can especially grow on where the pinky is, the smallest finger, and it usually comes out the side of the finger where it has the extra digit. And is there any webbing? Now, all these things can happen. Another good thing to consider when you're pregnant is to think about, maybe are you going to bank the cord blood? Because you've got to get with the service that offers that. And it's called cord blood banking. And what we do is we collect the stem cells right from the umbilical cord. These are the beginning of cells, okay? These are able to actually regenerate disease cells. So these are pure cells that we can take from the cord, okay? And then we take and we put into a special container, and it gets put into ice, okay? You want to keep it cold, and it gets shipped off to a facility to that banks blood, okay? So mom has to get all the information, got to ask, make sure her provider will do that. Tell the nurse when she comes into the labor room that she wants to bank her cord blood, all right? And so that we have the kit and everything ready right there, so that we have to draw the blood out of the cord and has to go. So there's a really a big procedure for all this, because you got to keep those cells just perfect, and they do help. I'm going to tell you, if you have a family member, you have any kind of problems in your family with inherited diseases, and you think that maybe one day you'll need these beautiful stem cells to replace those disease cells, then you might want to look into cord blood banking. It's not cheap, okay? So say, for instance, in my family, we have some blood dyscrasia. So what we did was everybody in the family paid for a year, okay? And if anybody needs those stem cells, they can get them. Now, the further you get away from the actual donation person, okay, the baby, the less effective it could be. All right. So for instance, somebody in the family has some knee problems, and they want some of those stem cells, they can get some stem cells and inject it into the knee to see if it can replace those disease cells. It's pretty good. And we have it in our family, and it's still in Tampa. That's where they have the cord blood banking facility. All right. So there's something that mom and dad had to think about before they get to the labor room. All right. Now that concludes chapter 6. So I'm going to stop my sharing. So I hope you enjoy the remainder of chapter 6, and be sure to look at the other PowerPoint for the beginning of chapter 6. Thank you so much, and have a good day. Keep studying, keep reading.